Alright, hello everyone. This video is going to be on atrial rhythms, specifically atrial fibrillation and atrial flutter, because those are some of the two most common dysrhythmias that we'll see in EMS or hospitals see in the emergency department of some patients. So I want to give you a little bit of background on both of these rhythms, and also we will look at what they look like on the ECG, and we will also talk about the clinical presentation of the patient, and also some treatment modalities that we can go toward in efforts of making the patient feel better. So to start with this, atrial rhythms are the most common type of dysrhythmia, especially in patients 60 years old or older. Typically they occur when some sort of ectopic focus or some area in the tissue that fires early in the atria when that stimulus assumes responsibility for pacing the heart. This could either be due to increased irritability, increased automaticity, or some sort of escape mechanism. Now, an ectopic focus is one that originates somewhere outside of the SA node. I got a picture here shortly that I'm going to show you just so you can see the normal conduction pathway and how the cardiac conduction system works under normal circumstances, and I'll compare that with what's going on with atrial fibrillation and atrial flutter. But again, in an ectopic focus, this is a focus that originates somewhere outside of the SA node, which would be abnormal considering the SA node is normally the dominant pacemaker of the heart. Usually this ectopic focus is somewhere in the left atrium or the right atrium. Because this atrial focus is outside of the SA node, any impulse coming from it would usually cause an unusual depolarization wave, thus causing the P wave to have an unusual configuration or an abnormal morphology or presentation. This atrial P wave can be either flattened, it could be notched, maybe peaked, or even diphasic, which would mean it would have two separate phases. Now, atrial rhythms as a whole, especially if they're very rapid, specifically atrial fibrillation, atrial flutter, they're very rapid. This takes a huge toll on ventricular filling time. It diminishes ventricular filling time significantly. And as a result of that, it's going to reduce the strength of atrial kick. And normally the atria provide about 30% of a patient's cardiac output. So again, if my ventricular rate is very, very fast, that's going to take a huge toll on my cardiac output. Most atrial rhythms are benign. They're really not that symptomatic. Our patient may not be symptomatic from most of them, but when they become a tachydysrhythmia, when they become so fast, the ventricular rate especially becomes so fast, that's when it's very, very dangerous, or it could even potentially be life-threatening for a patient. And again, just to remind you, the atria may discharge faster than the sinus node due to increased irritability or increased automaticity of maybe one individual cell or maybe a group of cells collectively. So again, that's a quick background on atrial rhythms themselves, but I want to go ahead and zoom in on atrial fibrillation and atrial flutter and why they're so important. The first picture I want to show you, though, is again just a recap normal electrical flow through the cardiac conduction system. So what we have here is we have a human heart, the big blue tube, or this blue tube here. This is our vena cava, of course, the superior and inferior vena cava. So our electrical stimulus starts in the sinoatrial node. I'm going to do this in red. So this is what sets the pace of the heart. This is the dominant pacemaker. It sits kind of right up there in the top of the right atrium, the corner of the right atrium. This stimulus sends or fires a signal and depolarizes the atrial. That SA node stimulus represents the P wave, which if you look on your strip here, these are our P waves right here. They're great. They're all upright. They look terrific. That's what we want to see when we're looking at a P wave. And P waves represent atrial depolarization. So when this signal fires, it's depolarizing the atria. And the normal conduction signal is traveling toward this next node, or this next piece of electrical conduction tissue called the AV node. Now, just let me go ahead and say this real quick. Normal firing rate for the SA node, which is this node right here, is 60 to 100. That's what our heart likes. Our heart likes to beat at 60 to 100 times a minute, and with the SA node being the dominant pacemaker, that's what it sets it at, somewhere between 60 and 100. So the next piece of tissue that the signal reaches is the AV node, again, which I've already circled in red, right? Actually, that's green, sorry, in red right here. Now, normal firing rate for the AV node is 40 to 60. Now, although that's the normal firing rate, that's the normal intrinsic rate for the AV node. So what that means is if some reason the SA node fails or does not fire, the AV node will then become the dominant pacemaker. However, it's only going to set the rate somewhere between 40 and 60. But under normal circumstances, 60 to 100 is a normal heart rate, but it's because that is set by the sinus node. The sinus node sets the beat or sets the rate, and all of the other cardiac tissue follows behind the dominant pacemaker, which again, in a normal healthy heart, would be set by the SA node. So 40 to 60, we're at the AV node. So the AV node represents, let me go ahead and erase these green. So the AV node represents your PR interval on your ECG strip. That's right there. So from the end of the P wave, difficult to draw, from the end of the P wave to the beginning of the QRS complex. So once the signal reaches the AV node kind of holds on to that signal for a little bit and does not immediately send it to the ventricles. The reason it does this is it wants to allow the ventricles time to fill with blood. If the AV node did not exist, blood would immediately spill into the ventricles, giving the ventricles no time to fill with blood at all. So as a result, that could take a toll on a patient's cardiac output, and they would have a reduction in how much blood they're sending around, which would be bad. So the AV node, when it's functioning normally is great. It's a great safety mechanism, and again, it allows time for the ventricles to fill. Now, once the signal reaches the AV node, it's going to start heading down toward the bundle branches, or toward the bundle of His specifically. So the bundle of His is really where the top of the branch, or the top of the bundle of His system, where it branches off into the left and right the left and right bundle branches. Each bundle branch is responsible for depolarizing that ventricle. So the left bundle branch, which is this one, is responsible for depolarizing the left ventricle, and the right bundle branch is responsible for depolarizing, which would be this, responsible for depolarizing the right ventricle. Now, the normal intrinsic rate for this, depending on what book you read, 15 to 40, 20 to 40, it doesn't matter, it's all relatively the same. That's the normal intrinsic rate for these ventricles, but again, it's not normally 20 to 40 because the SA node sets the pace of the heart. So these ventricles are used to beating at 60 to 100 times a minute because that's what's required to sustain life. However, if we have failure, so let's say our SA node is not firing, our AV node is not firing, and our junctional tissue, which is about somewhere in here, is not firing, the ventricles may become the dominant pacemaker of the heart, where their intrinsic rate is 20 to 40. So they're going to start contracting the heart 20 to 40 times a minute, which is not good enough. It's not going to sustain life. It's incompatible with life after so long. So they're getting really sick. So these ventricles, or the bundle branches, the bundle of His system, and the ventricles themselves, they're depolarizing the ventricles. So what's represented on the ECG tracing is your QRS complex. Your QRS complex, which I'm circling in blue right now, that represents ventricular depolarization of the heart. And the T wave here, I'm going to circle in green, is ventricular repolarization. So that's when the ventricles are getting back to a resting state, or a more negative state. And then the cycle just repeats itself. The SA node fires again, talks to the AV node, the bundle of His, and then the Purkinje fibers, which is the very distal points of the cardiac conduction system, really the lowest point, so to speak. So that's a normal beat. That's what happens in the normal cardiac conduction system when it functions under normal circumstances. That's what we want to see. Go ahead and erase these. So again, that's normal. That's what happens with normal electrical activity through the heart. Next thing I want to talk to is some abnormal patterns, which would be this, atrial fibrillation. So again, I'm going to zoom in on atrial fibrillation and atrial flutter because they're the two common dysrhythmias that cause patients to be sick or become symptomatic. So let me go ahead and first give you a little bit of background on atrial fibrillation itself and why it's so important to understand, especially in medicine. All atrial rhythms are very, very common, but atrial fibrillation itself, this is really one of the most common dysrhythmias that patients experience. Again, especially patients over the age of 60. It's also often found in patients with some sort of chronic lung disorder, such as COPD, emphysema, collectively chronic bronchitis. Also, if patients have some sort of underlying cardiac disease, such as previous heart attacks or some sort of valve disease, heart valve disease, that can also precipitate atrial fibrillation, and it can be chronic. So patients live with this dysrhythmia every day. They live with it. However, they're usually immediately put on anticoagulation treatment, such as Coumadin, to help prevent the whole thromboemboli issue that may occur with atrial fibrillation. And usually those patients do just fine as long as their ventricular rate stays normal, stays where it needs to be. Usually those patients live a great life without really experiencing any symptoms. In this rhythm, as you can see with the ECG strip I have here, notice we do not have beautiful P waves like we did in our last rhythm or our normal sinus rhythm. Our P waves here are just kind of fibrillating on the baseline. That means they're essentially quivering in one spot. They're not really generating any effective contraction whatsoever. So as you can see, just the underlying issue here, we have essentially a communication problem between the atria and the ventricles themselves. The atria are literally just kind of fibrillating there in one spot, not adequate enough to cause a contraction. Many foci are firing simultaneously, or maybe even one right after the other. And they're all competing for control of the heart and basically throwing the atria into total chaos. The atria themselves can discharge upwards to 350 times a minute, and sometimes even higher than that, maybe on up into 500-600 range. Now, the most important thing with atrial fibrillation when it comes to really treating your patient, or the immediate concern, the immediate question that you should be concerned with, is their ventricular rate. AFib with very fast ventricular rates can drop the cardiac output significantly. In this dysrhythmia, the ventricular response rate, or RVR, as I'll mention here in a few more minutes, this is usually included in the rhythm identification. So right now, all we see is AFib. What's our rate? 1, 2, 3, 4, 5, 6, 7, 8, 9. Our ventricular rate here is about 9. You could argue maybe 100. So about 90. That's good. So this can even be considered controlled AFib because it's a ventricular rate between 60 and 100. That's what we want to see. That's okay. This patient's probably doing just fine. However, if we add some more beats, so these lines that I'm about to draw, assume that they are QRS complexes, because remember, these QRS complexes represent ventricular depolarization. It's assumed, although this is only measuring electrical activity, it's assumed that cardiac contraction occurs right after this muscle is depolarized, or the ventricles are depolarized. So again, what I've circled in blue is each one of those represents ventricular depolarization. So I'm going to go ahead and erase those so you can see the rest of the rhythm. So if we have rapid ventricular rates, assume that each line I'm drawing is a QRS complex. So we're adding to our rate. So our initial rate is 1, 2, 3, 4, 5, 6, 7, 8, 9, 80, 90 maybe. So now let's look at a rate. 90, 100, 10, 20, 30, 40, 50, 60. So now we're at a rate, let's add one more. So now we're in atrial fibrillation with a ventricular rate of 170. So that means our ventricle, let me go ahead and write that down so I don't forget. So our ventricular rate, ventricular rate is 170. It's really, really fast. It's not good. With my ventricular rate kicking this fast, let me backtrack. So atrial fibrillation itself, just the underlying rhythm itself, is already a communication problem between the atria and between the ventricles. So now we're adding to that complex problem. Now we're adding a reduced ventricular filling time because my rate is 170. My ventricular rate is 170. So let's do some math here. Let's go back to our cardiac output formula, which we should remember is cardiac output equals stroke volume times heart rate. Let me go ahead and move my device here. CO equals stroke volume times heart rate. So if my heart rate is 170, that's going to take a toll on my stroke volume, because remember, normal stroke volume is 70 milliliters. However, if my ventricles are kicking 170 times per minute, I'm not going to have a stroke volume of 70. It's going to be significantly reduced. And on top of that, my stroke volume's already reduced just because of the AFib, just because I've lost my atrial kick, which is responsible for 30% of my cardiac output. So let's say our cardiac output is, our stroke volume is 20. So let me go and write that down. Stroke volume is 20. So now we have a heart rate of 170 times 20. That's a cardiac output of 3,400 milliliters. Remember, our normal range is 4 to 6. We want to see 4 to 6 liters. So that's a pretty significant drop, and the patient's probably getting pretty symptomatic with this. And again, his stroke volume may be even, or his or her stroke volume may be even less than 20. So the patient is really getting symptomatic because of the reduction in their total cardiac output. Now, on the opposite end of the spectrum, they could be in atrial fibrillation with a slow ventricular response, so SVR. That's essentially this same rhythm, and I can't really erase. Well, I guess I can. Let's play around here. So imagine everything I'm crossing out, there's no beat there. So now we have I'm going to go ahead and cross this out over here too. So now we have 1, 2, 3, 4 QRS complexes. So now we have atrial fibrillation with a slow ventricular response. So the SVR just simply refers to that your ventricular rate is typically less than 60. So the patient may be symptomatic here as well. So let's say my heart rate is 34. So I'm in AFib and my heart rate is 34. So let's go back to our cardiac output area over here. So now I have a heart rate's 34. So that's my heart rate, and then I'm working a little bit backwards here. My stroke volume is probably doing okay because my ventricles have plenty of time to fill. My heart rate's only beating 34 times a minute. My ventricles are only contracting 34 times a minute. So they have plenty of time to fill with blood, so we'll even overshoot it. Let's say my stroke volume is actually 90 when it's normally 70. We'll actually increase our stroke volume. But let's see what it does to our rate. So we've got 90 times 34. Well, that equals 3,060. So just slightly over 3 liters. That's a whole liter less than 4. And my cardiac output may be 5 liters. So that's almost a 2-liter reduction in my cardiac output. So I'm starting to get symptomatic. I may be getting dizzy. I may be getting sweaty. I may be getting nauseated. Obviously, my heart rate's way too slow. So it's ultimately bad. And the patient can be extremely symptomatic, no matter which end of the spectrum you're on. If you're going too fast or you're going too slow, doesn't really matter. So, again, back with atrial fibrillation. With the rapid ventricular response, there's many things that could induce that or cause their ventricular rate to really become chaotic, really become very, very fast. Number of issues. Same thing as slow ventricular rates. They may be on some medication. They may be on a beta blocker. They may be on a calcium channel blocker or other medicines such as digoxin. Digoxin would be a good one for atrial tachyarrhythmias. They may have accidentally taken too much of the medication, and with digoxin, it's one of those drugs that has a narrow therapeutic index. So it's not easy for the patient to unintentionally overdose or relatively overdose on the medication, and that may slow their heart rate down and could make them sick as well. So some causes of atrial fibrillation. Again, it's one of the most common dysrhythmias for patients at 60 years or older, but valvular heart disease would be one, and I'm actually going to write these down for you just so you can see. So, causes: valvular heart disease, usually the mitral valve, some sort of disease to the mitral valve. Hyperthyroidism, some sort of infection. So it's not uncommon that patient may be septic or relatively septic. They got some sort of infection. They may not always go into sinus tachycardia. They may be always in a sinus rhythm. However, they may convert because of the infection. They may temporarily convert into atrial fibrillation. Their ventricular rate could get a little bit up. So it's actually not uncommon at all to see someone with a fever, especially an older person that has a fever, some sort of infection that may be in atrial fibrillation, even though they're not normally in atrial fibrillation under normal circumstances or every other day. Coronary artery disease, so really any underlying heart disease problem, whether it's congestive heart failure, coronary artery disease, previous MI, pericarditis. So I'll put pericarditis, but again, a long list of problems. So CHF again, MI. Some drugs can cause some atrial fibrillation. Aminophylline, it's not really prescribed that much anymore. I think some doctors still do, though. Digoxin can even precipitate an atrial fibrillation as well. But again, the rate is what's so concerning here. So as far as our clinical presentation with someone in AFib, usually if they're not tolerating that ventricular rate, they're going to be sick, and they will have some outward signs of them being sick. They may be nauseated, they may be sweaty. Obviously, the heart rate's up. If it's on the RVR end, the heart rate's up. They're probably breathing fast. May even be having some sort of pain, dizziness, maybe a syncopal episode. A lot of different things as far as your presentation with that. Now, the treatment for these patients, depending on how stable they are, and you can start with medications such as diltiazem or some other calcium channel blocker. Usually diltiazem, though, maybe verapamil. Digoxin, they may already be on digoxin anyways. Some doctors still like to use digoxin. Those are the big ones. A little less common with beta blockers, but they can be used. And again, with atrial fibrillation, they are at risk for stroke because let me go back to our last picture here. So if I have atrial fibrillation, then somewhere in my atrial tissue, doesn't matter which right or left, I have some ectopic cell is firing just chaotically due to increased irritability, automaticity, doesn't matter. Blood pools as a result of my atrium not being able to kick that effectively. Blood is going to pool in these areas, and no matter where it's at in the body, if blood pools or sits too long, it's going to start to clot. So the concern with people with chronic atrial fibrillation, the concern is that they're going to form a blood clot somewhere in their heart, and that blood clot may go to one of three areas. That would be a big concern. It may get lodged in the coronary artery. That would be an MI. Now you have an MI because an embolus moved down into the coronary arteries and it secluded them. That's an MI. It may go to the lungs. It may obstruct a pulmonary artery, which would make it a pulmonary embolism. It may even travel all the way up through the bloodstream to the brain, and now the patient has a stroke. So that's our three big concerns. It may go to the heart, may go to the lungs, it may go to the brain. So again, that's one of the reasons this patient's usually put on some sort of chronic anticoagulant for management of that. So that's atrial fibrillation. Now, let me go back to my atrial flutter picture. Not too much different. I mean, the treatment here is pretty much completely identical as far as how these patients are managed. Again, the causes of this rhythm pretty much the same as atrial fibrillation. Some sort of valvular disease, usually the mitral valve, hyperthyroidism, pericardial disease, pericarditis, MI, COPD, some sort of right-sided heart strain. However, one of the big differences between this and atrial fibrillation is this one is actually rarely seen in healthy people. Some healthy people have AFib and they live healthy lifestyles. This one is a little bit less common with your healthy population. Usually if they have this rhythm, they do have, or most likely have, some sort of underlying cardiac disease. Now, with the clinical presentation, again, really depends on ventricular rate. So depends on the ventricular rate. Too fast, too slow, doesn't matter. Patient may be symptomatic on one way or the other. It doesn't matter. Now, as far as the treatment for atrial flutter and atrial fibrillation, again, pretty much the same. So if the patient's otherwise stable, they have a good mental status, their blood pressure's okay, they're talking to you just fine, they answer all their questions, appear to be doing otherwise well, you can usually start with a rate control drug, again, such as diltiazem or a calcium channel blocker. But this is really the biggest one, or some other calcium channel blocker, if they're otherwise stable. Now, if they are unstable, meaning they may have an altered mental status, their blood pressure is really, really low, their heart rate gets really, really high, their ventricular rate gets extremely high, the 180, 190, on up into the 200s. If their ventricular rate is really, really fast, that's really concerning, and that could really take a huge toll on their cardiac output. So whether it's atrial flutter or atrial fibrillation, doesn't matter. If your ventricular rate gets way too fast, the immediate treatment is synchronized cardioversion. Now, this is not the same thing as defibrillation or shocking a patient. The term shock, it can be used interchangeably with defibrillate, but you cannot use either one of those terms when you're talking about synchronized cardioversion. Synchronized cardioversion is when you're sending a controlled dose of electricity at a certain point in the cardiac cycle, usually right before ventricular contraction. So, usually if you have a monitor, or you're using your cardiac monitor, if let's say for instance we had the same rhythm, but let's really jack our ventricular rate up, which is what we're doing right here. So let's see our ventricular rate now. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21. So 210. Our ventricular rate is 210. Let me go ahead and write that up there. Obviously way too fast. So, if you have this patient on the cardiac monitor and you like to synchronize cardiovert them, it's very, very important that you hit the sync button on your monitor. What that's going to do is it's going to form a line on right where your R waves are. So you're going to have a line formed on all of your R waves of all your QRS complexes. Should be on every one of them. That's going to indicate that your monitor was able to sync with that underlying rhythm. So what's going to happen is when you charge your monitor to your joule setting, and again, it depends on your protocol, depends on the doctor as to how much electricity you want to use, usually between 100 and 150 to start with atrial rhythms. But when you hit the sync button, you expect to see these lines or these markings on the R waves, because that represents ventricular depolarization. You're putting it right onto the R waves in the QRS complex because you're wanting to send that dose of electricity right when the ventricles are getting ready to contract. So once you hit your sync button, we've got our indication, we've got our lines, that's our electrical evidence that it's captured. We want to charge our monitor, we'll say 100 joules just for giggles. So we charge it 100 joules, and then you will depress the shock button or deliver the shock. So that is going to send this electric charge right on where those R waves are, right during ventricular depolarization, in efforts of you're not really restarting the heart. You're trying to convert it into hopefully a better arrhythmia. It would be ideal to put it into a sinus rhythm, but your goal is to hopefully convert it into some other rhythm. Again, hopefully a sinus rhythm. This can be used for atrial fibrillation or a flutter. It can be used for all sorts. It can even be used for SVT. But the purpose of this discussion is just atrial flutter and atrial fibrillation for when it can be used on this patient. And again, usually there's really good efficacy with synchronized cardioversion. Usually you will not have to do that more than once or twice to your patient. It's very, very effective treatment modality for this rhythm. Usually it'll convert it within one or two cardioversions. Again, notice I didn't say shock. Do not say shock or defibrillate. That's completely different. Defibrillation is when you're trying to depolarize the entire myocardium at any random point during the cardiac cycle. It doesn't matter. The patient's in a bad dysrhythmia. You're just trying to restart it, get it out of that. Sync cardioversion, you're trying to, again, send a certain dose of electricity at a certain point in the cardiac cycle, usually right before ventricular contraction. So I think that's long enough. Hopefully this has cleared up some things with atrial flutter and atrial fibrillation. Stay tuned for some more videos on the cardiology subject as well as pharmacology as well. And I hope everyone's having a great week. Thanks.